You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 1st, 2021. This week, coronary artery calcium and exercise, translating clinical trials, the question of metabolically healthy obesity, and more on left atrial appendage closure. First, a note on COVID. It is getting better, thank goodness. But to not lose any more friends or have any more folks complain to my employer, I will move straight to cardiology. Let's talk about coronary artery calcium and exercise. South Korea investigators have published a provocative paper on the association between coronary artery calcium, CAC, and physical activity. Now, since this involved a seeming paradox, it got a lot of attention. The study was a convenience sample of about 25,000 participants without coronary artery disease from two hospitals who happened to have had two coronary artery calcium scans done. The authors used three groups based on self-reporting of activity. Group 1, inactive. Moderately active was Group 2. And the third group did health-enhancing physical activity. Now, health-enhancing physical activity corresponded to the equivalent of jogging 3.5 miles per day, so it's pretty significant exercise. The study looked at the baseline coronary artery calcium score and the change in CAC over time in the three groups. But before I tell you the results, we should review three basic facts. All right, number one, heart disease is a leading killer because of coronary plaque rupture, which leads to a clot in the vessel and sudden occlusion, then MI or a sudden arrhythmia like VF. A basic tenet taught to medical learners, one that has stood the test of time, is that sudden plaque rupture is more likely in less obstructive, younger, less calcified plaques. The 90% calcified lesion is more likely to cause angina, but it's that 20% softer plaque that often causes sudden occlusion. This is why a person can pass a stress test and die the next week. A stress test only picks up a 70% or greater lesion, but in general, it's the non-ischemia causing 10 to 20% soft, friable plaques that are most likely to cause MI. Okay, second fact, coronary artery calcium means exactly what you think, hardening of the arteries. It's what we call a surrogate marker for advanced atherosclerosis of the coronary arteries, and it can be calculated from a CT scan. But, the presence of hardening of the arteries does not necessarily mean one will have an event, and the absence of hardening of the arteries does not inoculate one from having an event. Okay, third fact. Most, perhaps nearly all the data on CAC use pertains to its use as a single baseline measurement to guide the use of statins. Now, this study is interesting because it looks at progression of CAC. The prospective cohort study had two major findings. First, physical activity was associated with having a higher prevalence of CAC at baseline and with faster progression of coronary artery calcium over follow-up. And that association was graded across levels of exercise. In other words, there was an increase in CAC with moderate activity compared to being inactive, but the increase in CAC was even greater in those who reported health-enhancing physical activity or higher levels of physical activity. Now, comments. I've talked to my friend Andrew Foy from Penn State about this study, so I want to give him credit for helping me understand it. And the first thing we should say that the major caveat of this study pertains to its generalizability of data from a Korean population to North America. For instance, if you look in Table 1, The average BMI of an inactive person in this trial was 24. The average HDL was 52. Is that really a representative sample of the average inactive American? I mean, maybe in Palo Alto, but not in central Pennsylvania or anywhere in Kentucky. Our inactive patients are much less healthy appearing on paper. But on the other hand, also noteworthy in this study is that 35% of each of these categories from Korea were smokers. Now that seems a bit high, higher than we have here. Now let's move to the study itself, and I think we should first say that these look to be pretty robust associations. I mean, despite the self-reporting nature of physical activity, the p-values are quite significant, and there's a graded association. That suggests that this is a non-spurious association. Also suggestive is that other studies cited by the authors show similar associations. For instance, we know from numerous papers that marathon running has a strong correlation with coronary artery calcium. So I think these are real, non-spurious observations. But here's the thing, we also know that there are oodles and oodles and oodles of papers associating exercise in lower rates of future cardiac events. Thus, the paradox here is that if the group that exercised more had higher CAC levels at baseline and more CAC over time, does this mean that exercise may have negative effects? Does exercise promote atherosclerosis and increase the risk of heart disease? No, of course not. Exercise does not elevate the risk of coronary artery events. It may promote CAC progression, but that does not mean it increases the rate of cardiac events. This study, of course, does not report events, which is the only thing we care about. To me, the observation that a clearly healthy activity, exercise, which nearly everyone agrees reduces future events, also associates with CAC progression, weakens the strength of CAC and CAC progression as a surrogate marker of anything important. And it isn't the only observation that makes me question CAC progression. Statins also reduce future cardiac events, but multiple studies find an association with statin use and CAC progression. So I see the major take-home of this study is that it casts serious doubt on the use of serial CAC measures. If exercise and statins increase coronary artery calcium, but these things also clearly reduce events, measuring CAC more than once seems extremely ill-advised. The main use of coronary artery calcium is to use it as a one-time risk modifier for people who are on the fence about taking statins. Proponents of CAC say the incremental value of knowing it is useful. For instance, zero CAC portends super low risk, and a high CAC in an intermediate risk patient may tip that patient into taking statins. But my doubt over this strategy remains. No single risk factor should be taken in isolation. While this study mostly weakens the use of serial CAC measurements, if you combine the associations of being an exerciser or statin taker with coronary artery calcium, I wonder whether the measurement of this surrogate marker tells us anything useful at all. Next topic is the new syntax score. The Journal of the American College of Cardiology recently published a study looking to validate the newest iteration of the syntax score. And I know that sentence sounds like utter gibberish, but please don't stop listening. Let me try and break down why this is a worthy topic for thinking about. The issue at hand in this syntax score is the treatment of patients with multivessel or left main coronary artery disease. Should we use PCI and stents or coronary artery bypass surgery CABG? Now, a second point of background. The original syntax score was designed to measure and rank the anatomic complexity of the coronary disease. Simply stated, if the disease was too complex, bypass surgery was better than PCI, but say simple focal stenosis that not near any branch points led to lower syntax scores, and PCI might be better. But the original score seemed to only predict survival or MACE in those having PCI but not having CABG. So smart people thought, let's incorporate more data points, more data like 7 clinical variables. Well, this new syntax score seemed to do a little better. But now the Syntax score proponents want to make it even better by using data from the 10-year Syntax trial comparing PCI to CABG in patients with multivessel disease or left main coronary disease. The twist for this new score, called the Syntax 2 2020 score, is that it discards patient sex and adds diabetes and smoking. I know, you're like, Mandrola, this is still gibberish. But here is why it's important to talk about. The idea is that in medicine, randomized controlled trials of two therapies, say PCI versus CABG, DOAC versus warfarin, target temperature management versus standard care, they give us average treatment effects, average. But within that group of randomized patients, there are patients who do better with one or the other treatments. So when you're in the clinic trying to decide about your patient, you wonder if she is average or for some reason may do better with one of the other treatments. And subgroup analyses of trials are limited because they only look at one variable, say male or female, diabetes or no diabetes. The Syntax 2 2020 score is a worthy topic because it tries to personalize RCT data by grouping together lots of characteristics, getting a score, then seeing whether this score predicts risk and treatment effects. One tries to individualize data from trials. This score could potentially be used by the heart team in helping patients with multivessel CAD or left main coronary disease decide on bypass or PCI. The idea of the heart team is that PCI docs are biased towards PCI and surgeons are biased towards CABG, but could this score function as, say, a neutral Martian? In November of 2020, last year, Lancet published the validation of the new Syntax 2 2020 score. Last week, JACC published the external validation of this new score using observational real-world data from Japan. Now, this JACC paper is full up with complex statistical methods that go way beyond the level of an AF ablation doc. The short story, as I see it, is that the new Syntax score, when applied to the real-world data, did okay at predicting 5-year mortality, but for major adverse cardiac events, it could not recommend the specific treatment with sufficient accuracy. I need to delve deeper into the stats and I would welcome any input, but to me, I worry that using such a score is fraught. For instance, when you look at major adverse cardiac events versus mortality, there are many more major adverse events than death. If the score were truly useful, why wouldn't it predict a more frequently occurring outcome? And the C statistics here were in the range of 0.7. Well, 0.5 is a coin toss, so it's a little better than a coin toss, but not much. Now, the editorial accompanying this paper from Dr. John Squires and Michael DeMaio does a good job sounding a cautionary note about making too much out of this score. They point out that the Japanese registry enrolled and followed subjects for 5 years, but the Syntax score was derived to predict 10-year survival. Thus, the longer-term validation in diverse populations are going to be required before use of the Syntax score can be recommended. The problem is that very few trials follow patients for a decade. Another problem, this one covered in a letter in the Lancet from statistician Nick Fremantle and surgeon Domenico Pagano, was that the Syntax score authors exerted bias in the choice of unrepresentative and suboptimal data sets for the creation of their new score. Fremantle and Pagano assert that the studies used to validate the score were too old. Why not use the newer Excel trial, which had in its 5-year results a significant mortality advantage to bypass surgery? So I've seen projects looking at similar efforts. For instance, the DAP score to help guide antiplatelet therapy post-PCI. There's a TopCat trial score to help guide patients with HFpEF who might benefit from spironolactone. And a neat program looking at trial scores to determine those in the Accord trial who would respond like sprint patients. Now, more on these sorts of efforts in future shows. And I definitely need to learn more about the details of these stats, but the quest to do better than the average effects from trials seems like a very, very hard one. For if you can say treatment A looked better than treatment B on average, but for my patient in front of me now, this score or my gut tells me that treatment B will be better, then I have trouble seeing the point of doing RCTs in the first place. This is a really hard topic, and I would appreciate any input. Head over to the heart.org and Medscape Cardiology, and in the comments, let me know what I got right and wrong about this. Next topic is, can the word health and obesity go together? A French observational study presented at the Eurodiabetes meeting challenges the often heard phrase metabolically healthy obesity. I see this scenario pretty often. A 350-pound patient comes to my clinic and tells me that the primary care doc said all was good. I'm like, really? Your doc said all was good? And the patient says, yes, here, I will show you. Look at my labs, all normal, and so is my blood pressure. The question is an important one. How large a risk factor is obesity alone? I mean, many patients who have obesity also have metabolic conditions such as diabetes, hypertension, and abnormal lipids, and we know these metabolic conditions predispose to future cardiac events. But what about obesity as an independent risk factor? The French study, first author, Grégoire Fauchier, which was simultaneously published in the journal Obesity, Diabetes, and Metabolism, looked at a 5-year period after discharge of patients with metabolically healthy obesity. A metabolically healthy obesity was defined by the absence of diabetes, hypertension, or hyperlipidemia. The comparison group was discharged patients without obesity and diabetes, hypertension, or hyperlipidemia. The primary outcomes were cardiac events. This was a big study of 300,000 patients with obesity. And of these, about a third, 90,000 patients, were metabolically healthy. Now, this was the active arm. Patients without obesity or metabolic conditions were the control arm. Let's go to the results. This was a young group of patients, aged 49 to 50, 30% male, 70% female. Metabolic healthy obese patients had a statistically significant, age-adjusted, higher rate of new heart failure and AFib. But the metabolically healthy obese did not have an increased risk of MI, CV death, or ischemic stroke. An interesting thing occurred when the authors looked at the comparison of the two groups based on sex. Here, metabolically healthy obese men had higher risks of heart failure and AFib, but women had lower risk, ranging from 50% lower to 1% lower. Let's leave aside the sex difference for the moment and talk about the main results. Given the many caveats of a retrospective observational study using administrative data of hospitalized patients, the trend toward higher rates of heart failure and AFib are highly plausible. The authors cite other studies which find similar results, and I've co-authored a paper with the Penn State group led by Andrew Foy, which also observed AFib as an independent risk factor for new AFib in young people. So I wouldn't want to make any definitive conclusions from this paper, but I do think it helps counter the notion that if obesity isn't associated with diabetes, hypertension, or hyperlipidemia, it should be brushed off as an unimportant health condition. I think the use of the phrase metabolically healthy risks minimizing the potential health consequences of obesity, especially when it occurs at a young age. I see the role of clinicians as health advisor for our patients. So it seems reasonable, therefore, to counsel patients with obesity that losing weight would independently reduce the risk of two pretty bad outcomes, heart failure and AFib. I mean, of course, we can do this advising with empathy and compassion. As I discussed last week, our words can both harm and heal. My approach in the clinic is to say something like, I know you probably know this, but your weight is a health problem, and as your advisor, I wanted to mention that trying to lose weight is super important, and I have some possible tips if you want to hear them. Now, let me go back to the observation that metabolically healthy obese seems protective in women. I don't think this is true. I mean, why would obesity be a risk factor in men but protective in women? Although I am no expert, I suspect there is a form of selection bias here, specifically a collider bias. What do I mean by that? Well, remember, we're not just looking at metabolically healthy obese women versus metabolically healthy non-obese women in the general population. We're looking at the sample of patients who are discharged from the hospital for some reason. So we're comparing non-obese, metabolically healthy women to metabolically healthy women who are discharged from the hospital. So an alternate conclusion that metabolically healthy obesity is protective is that what if there was something else, some other causal factor that caused non-obese women hospitalized to have a higher risk, say, I don't know, cancer, autoimmune diseases, or something else. I think a pro tip is whenever you see a paper touting a paradox, such as obesity or smoking being protective, always think about collider bias. I will link to a classic paper on this in the show notes. This paper shows that obesity looked protective for pediatric diabetes, and it was a flawed finding based solely on selection bias. Final topic today is the FDA is investigating Watchman Complications. Now, during the August 20th episode of This Week in Cardiology, I covered an observational study of Watchman registry data that found women had a significantly higher rate of inpatient complications. JAMA Cardiology published this study. Douglas Darden was the first author. Women were more likely than men to experience a major adverse event after Watchman. It was 4.1 versus 2.0%. The odds ratio was over 2. Now, this week, FDA announced its investigation in a letter to healthcare providers. I know that literally everyone that listens to this podcast knows that I am skeptical of percutaneous left atrial appendage closure, but this is very concerning data. Now, proponents will say the newer iteration of the device will be better, but that is pure speculation. Recall that one of the main uses of registry data is to investigate real-world complication rates. It's also likely that the registry surely represents a low estimate as it only captures in-hospital complications. That women were more than twofold more likely than men to have a major adverse event from the implant is vitally important for decision making. It's also totally plausible that women are at more risk. Women have higher complication rates from many different procedures, cardiac surgery and AF ablation, for instance. One of the things that concerns me about this procedure is its use in the real world. Registry data also shows that most devices are done by low-volume operators, and my anecdotal experience from here is that the device is being done in older, sicker patients. Remember, friends, trials almost always represent a best-case scenario. When therapies are used in patients with multi-morbidities, it is likely outcomes will be not as good. And in Watchman's case, the trial results were highly dubious to begin with. So that's it for this week. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, give us a rating, write us a little review. That helps others find us. And to those who have been writing comments on the heart.org Medscape Cardiology website, I want to say thank you and please keep it up, especially this week. Let me know what you think about some of these fairly challenging topics. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.